textbook so you can see what we went over today in class. So first, if you've already looked, you've seen the assignment is kind of looking at these pages in chapter 10 for the bony thorax. The sternum, the ribs, and the T-spine make up the bony thorax right here in this little paragraph of your book. So we have 12 pairs of ribs, we have 12 thoracic spine. T-spine number 1 lines up with rib number 1 posteriorly, and then it comes around anteriorly to the front. We're going to look at this anatomy of the sternum more tomorrow. Here's a view of that attachment, counting the ribs from the posterior aspect. And so we have 12 pairs of ribs, and we can break those up into true ribs and false ribs. The true ribs are ribs 1 through 7, where the false ribs are 8 through 12. And the difference is the way they attach to the sternum. The blue here is the costal cartilage. So 1 through 7 has its own costal cartilage, where 8, 9, and 10, and this blue is on it all jumbled together to connect to the costal cartilage of rib number 7 to then attach to the sternum. 11 and 12 are floating ribs. They are still considered false ribs, but they're also special because they're floating. They don't have any attachment anteriorly, no costal cartilage. They only attach posteriorly to the spine. Now looking at the rib, the next section in your book talks about the rib itself. The vertebral end, where it connects to the spine, has the head, and then there's a little skinny area of the neck and a bump off the side called the tubercle. As it curves around to come into the anterior portion, we have the angle of the rib and then the body and shaft. On the inside of the rib, you have a little groove for blood vessels and nerves, and this little groove holds them really close inside the rib. They line all the way around, and that's why if you do get a fractured rib, you have so much pain from it, because there's nerves and blood vessels that run along there. The posterior end of the rib has about a 3 to 5 inch difference between the posterior and anterior, because they do curve around down in the anterior portion of the ribs. This other picture shows the widest diameter around ribs 8, 9 area. Some of our landmarks you already know. Now this diagram, next page is over, shows you those articulations. So the costal cartilage attaches to the ribs and to the sternum. So we have a costosternal joint and a costochondral joint where it attaches to the ribs. This diagram here kind of shows you letter C and letter A are those 2 joints. In the back, this little tiny spine picture shows you how the head of the rib attaches to the vertebral body. So the head and the vertebral body. This is letter G, the costovertebral joint. Over here, the little bump, the tubercle of the rib, attaches with the costotransverse joint. That movement chart is one of your homework assignments for today too, to kind of break that down. So all of them have this plane gliding motion. If you look at the movement type on the chart, plane gliding all the way down. Most of the movement is diarthrodial. There are 2 parts that are synarthrodial, which means they are immovable. They do not move. And that is all of our unions where the 1st through the 10th costochondral unions are, and then at the first sternocostal joint. So let's go back up to that blue chart where you can see those. So the first one, letter C, kind of cemented, not movable. And where the ribs attach all the way down, not movable. Everything else is plane or gliding. So that kind of makes that chart a little bit easier to understand. Then we went into positioning and some positioning considerations for the ribs. So first thing, you want to ask your patient where the pain is, because we need to figure out if it's anterior or posterior ribs that are injured. Also, is it the upper or lower ribs? So first, what is upper ribs? In this little section, you'll see in bold the upper 9 posterior ribs. So upper posterior ribs 1 through 9 are considered upper ribs. If it's anything lower than that, then we will consider it below the diaphragm. Now, the reason this is important is for respiration and for centering. On an upper rib x-ray, you want to do inspiration. On a lower rib, you want to do expiration to move the diaphragm. You will see there is a difference between the KBP ranges, just slightly. Upper ribs says around 70 to 85, where lower ribs start at 75 to 85. So lower ribs are a little higher because they are over some abdominal structures like the liver and things that are needing a little bit more penetration. Centering for the upper ribs is just like a chest, T7, where centering for the lower ribs here is a little bit different. The wording is midway between xiphoid process and inferior rib margin, and you'll also see a note in the positioning saying the top of the iliac crest is about where the bottom of your light is going to be. So pretty similar to an erect abdomen x-ray. So here's some oblique ribs. On this one, you can see the left side is the area of interest. This is an LPO to show the left posterior oblique ribs. We always do a chest x-ray. This is a PA erect chest to rule out pneumothorax or hemothorax. As we scroll down through past the sternum positioning, you'll see in your book the ribs positioning pages. These are the ones you're going to see on the video we made for you. That is your matrix. You want to make keynotes on some of these important parts that we went over. So the above or below the diaphragm. Centering. PA or AP depends on where the pain is. If it's posterior, you want an AP projection. If it's anterior, you want a PA projection. It's right here in this little note. These are considered bilateral. We're getting both sides on these images, so you would do crosswise or landscape. Unilateral would be portrait, and you would just center off onto that side of interest. We are going to do bilateral ribs though. So we're going to do an AP or a PA depending on where their pain is, upper or lower centering and breathing. And then we're going to do an oblique. The oblique picture is going to be just the side of interest. So an RPO is going to be right posterior oblique position, where this one is an RAO for the left anterior oblique. So your anterior ribs are going to be the away side, and posterior are going to be the downside touching. So this one is an LPO for the left posterior ribs. So I have some scenarios you can fill out tomorrow to look at that. Here's an LPO, left side's elongated. If I was to give you that as an x-ray, it could look the same as an RAO. LPO, RAO, both would look the same. The left side would be elongated. Homework is to make your own bony anatomy of the ribs, labeling true and false ribs, and specifically pointing out the joint articulations that we went over for each area. Costovertebral, costotransverse, sternocostal, costochondral. Are they plain gliding, synarthrodial, or diarthrodial on each? And then a picture with the ribs that you can find online. Print that out or upload it to the assignment for today. Tomorrow's quiz will be over all of this that we just went over, either anatomy or positioning questions.